I brought a few things to share with you today, but I will kind of give you a little bit of my background, so to speak, because I think it's helpful in what I've experienced, I guess, over the last, I'll say 30 years plus. But I started actually at Alton Memorial Hospital as a staff pharmacist in 1980, as Rusty mentioned, coming out of St. Louis College of Pharmacy. I'd done some time up at U of I, Champaign, pre-med, and finally kind of settled on pharmacy instead. And then later when I got my MBA out at SIUE, so really I've been around here locally. Spent most of my career at Alton Memorial. Back when Alton Memorial Hospital was part of Christian Health System, which happened back in the late 80s. There was a merger in '93 that brought Barnes Jewish Hospitals, which had just merged, together with Christian Health System. So we kind of, as Alton Memorial, went along for the ride, which I think has been a great ride, not only for the organization, but for myself, because it really opened the door for a lot of opportunities for me personally, and I think a lot of opportunities for Alton Memorial Hospital. And I'll kind of get to that a little bit in a few minutes, but wanted to spin, and I'm certainly not the expert on the Affordable Care Act, but I'm going to want to tell you sort of how it's impacting not only Alton Memorial Hospital, but every hospital and health system across the country, and then sort of how we, Alton Memorial Hospital, and maybe other hospitals and health systems are sort of responding to that. So think back, back in 2010, when the Affordable Care Act became law, lots of things started to happen. And most of the things that started to happen was associated with how much we get paid. Because built into the Affordable Care Act over that 10-year time frame were automatic reimbursement reductions in our rates for Medicare. So every year from 2010 until 2020, we get a 0.75% reduction in our reimbursement called, it's for productivity enhancement, is what they call it. That's a haircut, yes it is. So, that certainly in itself was a big deal, because across hospitals in the country, that's equates to about $250 billion over that time frame. So then, on top of that, obviously lots of other things started to kick in. Many of these concepts were already sort of in the waiting with Medicare. They were already kind of thought through, and this was just a way for them to sort of be implemented in what I would call a more expedient process. And so if you think about that, it's really the pay for performance component. So if you've heard anything about, you know, value-based purchasing, increased quality, improved patient safety, and all of those things, really now there is either an incentive if you're sort of above the line, so to speak, for additional reimbursement, but also a disincentive or a penalty, so to speak, if you're below the line. It's budget neutral for Medicare. They don't really pay a dime extra, but the bottom 25% of the hospitals then pay the top 25% of the hospitals, while the other 50% sort of stay even Steven. So you can see everybody's kind of, all the hospitals obviously are trying to race to the top to get that extra incentive, but only 25% of them are there. I think the good news is for Alton Memorial Hospital, we have been there through the first 3 years of the Affordable Care Act, and so we have gotten a small incentive, and that kind of cranks up every year, so we do get some additional reimbursement back. There's another thing out there called readmission penalty. You've probably heard about that in the news. Really, that's associated with a penalty for people who get readmitted to the hospital within 30 days for the same diagnosis, and that can be heart failure, pneumonia, or heart attack. And again, if you're above the line, you're good, you're golden. You really don't get any more money, but if you're below the line, you get a penalty, and that cranks up each and every year. It went from 1% to 1.25%, 1.5%, eventually getting to 2%. And again, everybody trying to push below the average. Well, obviously, not everybody can be below the line in this particular case for lower readmissions. So half the hospitals in the country really then take, again, another rate cut. So a lot of things are changing around that because of how we get paid and how much we get paid. that gets to the sort of the where care will be provided. All of this is happening because of this. And I like to call this one the hockey stick graph, because as you can kind of see over the last decade, healthcare expenditures, and that's what this graph displays, have exponentially increased. And the top line there, the blue one, which is the highest, is hospital expenditure. The one right below that is physician. So you can see why all the sites, so to speak, are on hospitals for the most part and physicians because of these expenditures. And obviously, as the budget deficit grows, the country cannot continue to afford those kinds of dollars going out through the federal budget, i.e. Medicare and Medicaid. What's driving that exponential rise in expenditures? Well, obviously, we got the baby boomers coming along, aging population, but we're also doing a much better job of taking care of people. So lots of folks are living longer. More chronic diseases then sort of tend to pop up in the elderly population. So this basically just kind of graphically shows that less than 10%, that little yellow bar there, of the population of the country actually spend almost 50% of the dollars that go out of Medicare each and every year. So that's why there's this huge focus on, as I mentioned, those chronic diseases. So think about heart failure, pulmonary disease, diabetes, all those things that really then drive those top dollar expenditures. And that's just kind of a side note on the readmission piece there, that the readmissions cost the federal government, $17 billion a year. So obviously, they want to reduce the readmissions. That is the right thing to do.
What's a CAD, a CIF, and a COPT?
A CAD is coronary artery disease, CHF, congestive heart failure, and COPD is chronic obstructive pulmonary disease. So what is happening and not happening right now? Well, I mentioned the mandated rate reductions. They are still taking place, and that impacts us to that tune of $250 million. Specifically for an example of Alton Memorial Hospital, over 10 years, that's basically $40 million sort of out of our pocket. The sequester, which is wrapped up into that, so right on the heels of all of that, then we got another haircut. This one even bigger, 2% reduction over 10 years. And certainly that has added to sort of the pain as the reimbursement continues to go down from the Medicare population, which, really is the biggest user of health care across the country. Medicaid expansion, which was part of the Affordable Care Act, is happening in about half the states, and the other half it is not. So as you certainly probably have heard about the battle there, state by state, because of the Supreme Court ruling, could not be mandated. So there then became a debate across the country of whether each state would expand or not. Example, Missouri did not, Illinois did. Now this is federal dollars, this is not state dollars. It is kind of a pass-through if you do expand for the first 3 years. And then they ratchet down those payments to the state in that fourth year by 10%. So at some point, then the state really has to take over that expenditure. The object there is for the state to put in some kind of plan to push down utilization in order to make those dollars sort of go down on the top side so they can afford the expansion. That for us as a hospital in Illinois was a good thing because it really then reduced our overall uninsured population by about in half. So we expect to pick up an additional probably $1.2 to $1.5 million, depending on that reduction in the eligibility of our population in that Medicaid expansion. We typically, so I'll mention the uninsured, so that is really somewhat the free care that we provide every year. We provide that to the tune of about $28 million. So all of a sudden, you can see how when the top side revenue reimbursement starts to go down, and if our free care continues to go up, it puts a real squeeze on what we're able to do. The insurance mandate, lots of things around that. I mean, that's what really the Affordable Care Act is built on, was the individual mandate per se. There's lots of things wrapped up in that, obviously, with the employer mandates, and that's been pushed out. But the issue here is the more that the employer mandates are pushed out and the individual mandates, obviously, folks don't sign up to the tune of what they expected, puts more pressure on us, because as that whole Affordable Care Act legislation was debated, hospitals somewhat gave up that $250 billion, assuming that they were going to get some upside when a lot of these folks who were uninsured became insured. And so obviously, if that doesn't happen and you don't get Medicaid expansion at the same time, there's no extra dollars to offset that $250 billion, and especially not that sequestered 2%. So that's what really is problematic right now for many hospitals across the country, and why you're seeing a lot of hospitals, and I just read it again this morning, in the midst of layoffs, consolidations into, if you're a standalone, you may be looking for a partner, so to speak, and we'll talk a little bit more about that. The other piece of this that's kind of mixed up in it and sometimes not is really this high deductible health plans. As over the years, health plans have become less affordable, so to speak. Premiums keep going up double digit in order to cover a lot of this stuff. Now, all of you employers are pushing back and saying, wait a minute, we can't afford this double-digit premium increase. And in many cases, employers move to these high deductible plans to offset that a bit. And so now what we're seeing on the flip side is folks utilizing their insurance, but then not necessarily being able to pay that $2,500 deductible. So all of a sudden now it becomes bad debt. Yes?
And that's one of the problems. Because if you have a poor person that's poor or in that low income, and they're under the law, you can't deny them insurance coverage. But the law kind of changed it where maybe they can sneak around and say, well, we're not denying you coverage, but we might deny you service. And they start sending out the bills for these co-payments and stuff to those people that can't pay them. And then the question becomes, can these hospitals deny service? Because they're not really denying them coverage, but they do have say they went in for a $10,000 procedure, and now they got to pay the copay. But they can't pay that bill because they're unemployed.
Right.
And they have no job. And then they're sitting on the bill, and then the family needs another service at that hospital.
Yeah.
And then they go back, and they got another $10,000 procedure. Who's going to pay that additional bill?
Right.
And then they got another family member, the kid's got to go in for a procedure at that same hospital.
Yeah.
Who's going to pay that?
It is a huge problem. I can tell you that, in our case, we're always working with those folks to try to, either put a, payment plan, or if they qualify for charity care, we'll try to work with them on that side. And many times we're writing off a lot of these dollars.
Well, I mean, the whole point of the system is not to pay for that everybody's covered and then have them debt. Once again.
No, I understand. The government was really trying to reduce their payment and push it back to, again, it's more of a tax. In a sense, it's a tax to a certain extent.
Yeah, so the point is at what point is the hospitals and the private sector going to say, you know what, we can't treat you anymore because you owe us this debt, and deny service based on treatment instead of service based on insurance.
Yeah. Well, in a sense, that is a problem. I mean, I can tell you that we would never deny service if it was needed, that's for sure. Part of the other thing here that is really, and I think is the right thing to do, and it really has pushed us to do a better job of thinking outside the box of managing these chronic diseases like diabetes and heart failure, reducing the times, because a lot of these people always end up, kind of coming back to us through the ER, or they're admitted to the hospital because, one, they couldn't afford their medications, couldn't get their medications. If they did, they didn't understand how to take them correctly. A variety of social issues, but really it's forcing us to really look at the big picture and try to figure out how we can do a better job helping to take care of them once they leave our four walls, so to speak. So as we move forward in this whole new world of healthcare, and I'm talking about this with my staff and my physicians almost on a daily basis, we really now have to work outside the four walls of our hospital and think about the bigger picture and partner with people in the community. As an example, we're doing with Senior Services Plus, because they're in the homes of many of these folks, and being able to work together to do what's right for prevention and wellness. So, you know, I think there is a lot of good things happening all around it within this change, and it really is a transformation within the healthcare world. Not everything that I've talked about, you know, probably is the right thing to do in order to get there, but I think it's the right thing to do to get there. So is it making an impact, all this work that we've been up to with readmissions and improving quality and safety and all those kinds of things? The answer would be yes. Because if you look at healthcare spending, as I mentioned that hockey stick graph, you know, it's been, in 2011, it was only up 3.9%, when historically it's risen by, you know, at least 7.5%, pretty much across the board. Medicare spending only up 1.5%, when historically it's always been between 4 and 6. And the readmission rate down by about 1.5%. Doesn't seem like a lot, but when you look at it across the country, it's 70,000 admissions to hospitals. Quality, just some examples there. Central line infections, which are really the infections in the lines of the ICU, you know, that's down significantly through that 4-year period of time. Surgical site infections, a lot of work has been done around that. Improved that 17%, and then just preterm births before 37 weeks, again down 1%.
The central site is not leaving the sponge in the body kind of thing.
Surgical site infections, no, that would be more foreign body. This is more where you would actually get an infection while you were in the hospital because of unclean activities or something like that. So, you know, everybody's kind of nervous. So what's our pathway to the future on this particular thing? Well, I can tell you at Alton Memorial Hospital, BJC Healthcare, you know, there's a lot of things changing, but one thing that's not changing is why we're here, and that's to provide health care for the people in our community, so all of you. So our mission, vision, and values are not changing. You know, our vision is to be the first choice for great care at Alton Memorial, and we're all about working together around patient-centered care, teamwork, accountability, the patient experience, you name it. We have lived and breathed what we call our value proposition for about the last 3 to 5 years. We've kind of tweaked it around, but it's always said that we want to provide the very best patient experience and family experience when you walk through the door of our hospital, and we want to provide the very highest quality of care that we can through an engaged staff and physician team. And so we have been talking that, and I've been talking about it the last couple of weeks, really as we kind of go forward, what are we doing differently to get to that same spot or better in the future? So the to-dos that at least I have on my radar screen, and probably many other people have, but maybe in different ways, is to add more value. So as I mentioned, sort of that higher quality. We're constantly looking at our processes, our workflows, you name it. I mentioned it down here. It really is kind of in the reduced cost area too, to really try to eliminate waste. And by waste, I mean like steps, you know, all kinds of activities that we do that don't really add value to the actual patient care, so to speak. It's something maybe we just grew up with, paperwork, documentation, and we can streamline that kind of stuff. Obviously, we have to be compliant from a regulatory perspective, but if there's something we're doing that we don't necessarily need to do, just because we did it 10 years ago or 20 years ago, let's get rid of it. Let's do something different. So we've got teams kind of stood up across the hospital, really all the time. We've got folks working not only interdepartmentally, but across our departments. So think about the ER to the ICU, the therapies, the pharmacy, the radiology departments. They all have to interact together and work together. And that's where we have sometimes problems with handoffs, those sorts of things. So really trying to figure out how we can streamline that and improve it and gain more efficiencies and eliminate a lot of the stuff that we've done for a long time to reduce our overall costs and improve our quality, and then improve our patient and families' experience. We also want to grow the right services. So if you think about it, you know, I've just talked a little bit schizophrenic here. From a hospital perspective, we always thought about increasing our revenues was about increasing our admissions. Well, now we're all about reducing our admissions. So those readmissions, you know, trying to keep folks out of the hospital. Can we take care of you on an outpatient basis, an ambulatory setting, those sorts of things, in a different way? So you're not always coming to our ER, because that's the right thing to do, and it's at a lower cost. So now we have to think about how else can we grow our revenues and our revenue stream. Well, a lot about what we're doing is really trying to focus on areas of growth, sort of on the procedural side, where we've actually seen patients leave our community in many cases to go somewhere else for care. Surgical procedures is a great example. I think, you know, we've seen in the past orthopedic procedures like total joint replacements. Many people go to St. Louis to have those done for a variety of reasons. We were about going out and recruiting a new orthopedic surgeon. That's Dr. John Sturton. He started with us last fall. Finished up a fellowship in New York on joint replacement. Is doing all the new, latest, greatest stuff. And he has gotten busy very fast. Excellent surgeon. We have Dr. Omatola, who another orthopedic surgeon. He's in the area. He's a sports medicine fellow. And so he's hooked up. He's the team doc for SIUE. We have athletic trainers across the community of almost every high school that our foundation supports that group. And so they're in constant contact with him. And I think he's done a great job as far as, you know, keeping kids healthy in sports. And then if they do get injured, he's there to help take care of them. We have another internist sports medicine fellow over in Edwardsville and spends some time in Alton. She is also working with SIUE. But we've really done a lot of work around that particular area. Cancer, that's another area where we believe many people were leaving our community because they get better, higher technology access across the river. We recently upgraded our equipment in our radiation center, so that we have what's called True Beam technology. So that's really the technology that focuses that radiation specifically on the tumor, and, you know, saves a lot of that surrounding tissue, and shortens in many cases the duration of treatment, so you don't have to go so many days or so many weeks, so to speak, in many types of procedures. So we just got that finished up in May of last year. We have Dr. Simmons there in that center. He's hooked up with Siteman Cancer Center through BJC, so he has access to a lot of the research protocols that they use. We have Dr. Ryan and Woodson on our campus. We moved them into our new medical office building a couple of years ago, combined our infusion centers, and really went about you know, increasing the level of care that we can provide to the Alton community. Can we do everything? No, and that's why we have Siteman Cancer Center across the river, and we know when we need to refer those patients on to something else or something different, and we're constantly interfacing with them each and every day. And then OB, we're all about growing there. We have increased, almost doubled our deliveries over the last 4 years. We were at about 400 deliveries about 4 years ago, and last year we finished at 730. So it shows that more moms are choosing Alton Memorial to deliver their babies, and that's a great thing. And their patient satisfaction scores have been outstanding. They do a super job. The only problem we have right now is we're running out of space. And so we're getting ready to expand our obstetrics unit. If you know the campus at all, right now the OB program sits in what's called the Olin building. And right next door is the original hospital building. And we moved all those beds out of there over to the Duncan wing in 2010. And we're going to kind of recapture some of that Smith space. And it's right contiguous with the Olin building. And then move a lot of the administrative and outpatient functions that we have in the Olin building out there, down the hall, create a new entrance and a new reception area. And then add our additional labor and delivery postpartum rooms in that Olin space. And so plans are pretty much done. It's about a $1.8 million expansion project, and we should be hopefully getting started in the next couple of months. We've already tagged Helmkamp Construction here locally to do that job for us. So hopefully within the next 12 months we'll have that done. There'll be disrupted during that time, so we're trying to figure out how to temper that to a certain extent for our patients and their families. But I think it's going to be really nice when we get done. So other stuff that we're doing, and I think it gets to that whole transformation component, find a better way. So, how do we have some way to access primary care without having to come to our ER if you don't have a doctor? Well, this is our first pass of trying to make that happen. We have a clinic, it's called Convenient Care. We just opened up in Godfrey. We need, we figured we'd get about 20 patients a day there. We're already out of the gate. We're seeing probably a dozen a day, which I think is pretty phenomenal. Part of it is a growth strategy, but also part of it is taking some of that excess capacity, that excess demand off of our ER during the late hours, so to speak, in the afternoon and evening. So this clinic's open from 2 p.m. to 10 p.m. So a lot of the primary care, so the bumps and bruises, earaches, sprains, and those kinds of things can actually go to the clinic and be seen quicker instead of start getting bottled up into our ER. And then our ER patients can actually be seen sooner. So
Where's that for you located?
the corner of Godfrey Road and Stanford Lane, right before. Yeah, we used to have a primary care position there. We had the space, so that's why we wanted to try it there. You'll see the sign if you drive by. It's right before you get to Lewis and Clark Community Hub. So if that works well, we're probably going to look at other areas where we can kind of replicate that in some of our communities. Then, as I mentioned, kind of retooling and transitioning from that inpatient care, that inpatient admission, to something more on the super outpatient side. So really, hopefully, being able to treat more patients outside the hospital in some way, shape, or form. And in many ways, we don't know what that shape and form is yet. But we're really trying to work hard to figure it out. Many people are trying many different things. And we're working together not only at Alton Memorial, but with our colleagues at BJC Healthcare. We're kicking off an initiative as we speak called Making BJC Better. And it's all about how do we transform ourselves into this new world. So what are other people going to do? Probably a lot of similar stuff. Depends on where they are and what they have the capacity to do. But where this is all kind of heading, and I mentioned on how we get paid in the future at the very beginning. Traditionally, if you think about it, since the 60s, we've been paid as a fee-for-service type basis. So we're paid for what we do. So if we do a CT scan, or we do a hospital admission, or an ER visit, we get paid for that specific episode, or that particular procedure. Where this is all going, and it's not a light switch that you're going to flip to get there, is what's called capitated risk and population health management. So BJC right now is in the midst of about the middle of a 3-year arrangement with Medicare called an Accountable Care Organization. So all of our BJC medical physicians, along with most of our privates, at least in Alton, like the Alton multi-specialists, are part of the ACO. The learning piece of this is population health management. So all of their Medicare patients that they see, so all of our primary care physicians who have Medicare patients in the Alton community are part of the ACO. And the idea is to manage this population so that we improve outcomes, so that's improving quality of care for these patients, but yet lowering the overall cost of care. So Medicare knows how much it costs to take care of this population of patients. Let's call it 50,000 patients. And let's say it's X at the beginning, and at the end of 3 years, it's Y. If there's a savings between X and Y, then, of course, Medicare gets half. Then the ACO gets half. And then the ACO can distribute it between the hospitals and the physicians. Obviously, in order to make that happen, to get to that shared savings overall, guess what's got to happen? Go back to what I talked about, where the real cost of dollars is, the hospital. So you're going to have to try to figure out how to keep people out of the hospital. So at this time, it's really in the learning process of a shared savings model. In the future, it's going to be that we may have to take risk, like an insurance company does, for that population of patients, so that we are treating them for a fixed amount of dollars. So no matter what we do, as I said before, now we get paid for each thing that we do. So no matter what we do, at the end of the day, we've got at least the the same or higher quality of care, but at a lower overall cost. Others, you know, are probably going to look for a partner. I mentioned early on that a lot of consolidation within the market is occurring. That will continue to occur, I think. People are going to, if they're independent now, maybe looking for somebody, a health system or somebody to join or to hook up with. The good news is Alton Memorial is already part of a large system, BJC Healthcare. The even better news is BJC just announced about a year and a half ago bringing together three other health systems with BJC to make a total of 4 health systems called the BJC Collaborative. And that's St. Luke's in Kansas City, Missouri, Cox Memorial in Springfield, Missouri, and Springfield Memorial in Illinois. So 4 big systems covering, in a sense, most of Missouri and most of central southern Illinois. Because since then, Southern Illinois Healthcare in Carbondale has joined the collaborative, along with Blessing Hospital in Quincy. So again, kind of already getting bigger. So looser affiliation today, but it really helps us right now leverage our size, in a sense, to reduce our cost of supplies, equipment that we have to buy, and things like that. The last thing I guess we could do is kind of say, oh, this is just the fad of the day. It's all going to go away at some point. We'll go back to the way it was. And I think that's a bad strategy. That's not going to happen. Because if we look out, 5, 10 years, we're going to see more patients, but we're going to get paid less to see them and take care of them. So we got to figure it out. The market is transforming. An example of that, I think, and really is kind of what Walgreens just did too last fall when they announced that they were moving from their defined benefit for health insurance to defined contribution. Well, a lot of people are saying that's just the first of many. That many of the large employers to start with, like Targets and Lowe's and others, are going to do the same thing. And so they get some predictability in their health care cost.